Well, welcome. It's a delight to be with you. I'm happy to have this opportunity, and I'm particularly grateful that Dr. Lin has shared some interesting and challenging cases for our discussion. And we will discuss those first. And then if we have more time, I have a series of cases on soft tissue tumors with an inflammatory pattern that I am beginning to prepare into a lecture, and maybe we can look at some of those slides too. So we'll begin with this slide here on your screen. This is, I believe, a 39-year-old man who has a retroperitoneal mass. And Dr. Lin, do you want to say anything more about where it was or the radiology findings? We don't know anything more about his history other than its location. And so we'll just begin to look at this. And just at low magnification, the things that strike me are that it's sort of low to intermediate cellularity. I can see at low magnification that we have some cellular pleomorphism. There's a few larger nuclei, and then some loose areas, and maybe a little bit of inflammation in here as well. So we will see what we can do to enhance the magnification here and move around a little bit. And so we don't see any thick-walled vessels. We see a few very thin vessels, maybe a little bit of fat, and some myxoid substance. And then the atypical cells here have somewhat variable nuclei and a spindly background with a little bit of myxoid tissue. Looking a little further, some small capillary vessels. A little bit more kind of intermediate nuclear pleomorphism. Not a lot of mitoses, no atypical mitoses, but just this very kind of pleomorphism. So when I look at a case like this, the location is very important. Retroperitoneal tumors as a primary tumor. The first thing we would think about. Let's see, someone is. So the first thing I would think about is well-differentiated liposarcoma. Even though we don't have much fat here, this kind of low-grade atypia and spindle cell pattern with a little bit of myxoid change would be in that category of well-differentiated liposarcoma. Now, of course, that's a tumor that has a potential to de-differentiate and form more solid and higher grade areas. This isn't really a high grade yet, but it is certainly more solid than the usual well-differentiated liposarcoma. The other things that I think about in the retroperitoneum would be inflammatory myofibroblastic tumor. This is not very inflammatory. It's more pleomorphic than that lesion is. I would think about a desmoid or fibromatosis type of lesion. But again, this has a little bit more pleomorphism than that tumor usually does. And then you have other sorts of things like sclerosing mesenteritis and retroperitoneal idiopathic fibrosis. Again, those usually do not have the cytologic atypia that we're seeing here. So for me, the first panel of immunostains, I think, would include, for me, things like desmin, beta-catenin, and then I would do markers that would help me with regard to well-differentiated liposarcoma. So in our laboratory, we can do P16. That is positive in many well-differentiated liposarcomas and not in any of those other lesions. CDK4 also can be positive. That gene is often rearranged or mutated. And then, of course, the pathognomonic change is the MDM2 rearrangement, which is demonstrable by FISH testing and in many instances with immunohistochemistry. So, Dr. Lin, you did some further studies on this case. Do you want to tell us what you found?
Yes, Professor. In immunochemistry stain, MDM2 and CDK found positive. Can you see in the folder I sent you?
Yes, let me see if I can go back to those photos and demonstrate those.
And that's mean in my department haven't got.
Let's see if I've got the immunos here. So here's the CDK4, and you can see that has a nice nuclear and some cytoplasmic staining on many of these.
CDK4 positive, some tumor cell, not all.
Yeah.
Not at all. Yeah.
And that's okay. You don't need to see it in all the cells. I would say, I don't know exactly the numbers, but I think CDK4 is positive in about 75 to 80% of well-differentiated liposarcomas. Now, the thing that's unusual here is that this patient is quite young, and the usual scenario is not to see this tumor until someone is in their 40s, 50s, or 60s even. So that's a little bit unusual and might make me wonder if this patient has some sort of a germline mutation that might predispose them to cancers. Fortunately, this tumor does not usually metastasize, and if you can resect enough of it to get the higher grade portions out, the solid portions, and then follow the patients with progressive CT scans, hopefully you can detect any dedifferentiation early and resect that before it becomes a problem. That's typically the management in our institution, but we present these cases in tumor board. We look for other options for treatment. But right now, there aren't any targeted therapies that I know of that target the MDM2 mutation or the CDK4 mutation in these tumors. So it's really pretty much surgery. Pretty much have to use surgery and very close follow-up to control the disease. Any comments or questions about that case? Well, if not, let's go on to the other case that we have. And this is another case of a retroperitoneal mass. This is a much older patient, and I'm going to, let's stop the share and show the right case here. Let me share the right image on this case. So this also is a retroperitoneal tumor. And as you can see, it's quite different from the other case. We have areas of high cellularity, and then we have intervening areas with no cells. And it's quite blue. In other words, it's very cellular. And so we'll take a look at this tumor and see what we see. So here, first of all, I notice we have some areas of necrosis in this spindle cell neoplasm. There is a quite high cellularity. These cells have a few mitotic figures. And we see sort of ovoid spindle-shaped cells. We'll look a little further, more necrosis. Some of these islands I thought were a little bit centered around vessels. This one looks like it has a little bit of whirling around a vessel. And so that's possibly a pattern. I refer to that as angiocentric pattern of growth. And then this sort of more further away from the vessels, you get the necrosis. That's a pattern. This angiocentric pattern is a relatively uncommon pattern in sarcoma. In this regard, we do see it in some carcinomas, melanomas, and so that's also a consideration. And of course, always think of melanoma because it can imitate just about every other known tumor. So this is, I think, a case where you'd want to rule out carcinoma, rule out melanoma, and then see what other soft tissue tumors might have this pattern. Smooth muscle sarcomas, or other sarcomatous lesions can involve the retroperitoneum as well. So I believe we do have some immunoperoxidase stains on this case, and we can go through those on this other screen. I'll share that. And so here we see CD99, which is highlighting the membranes of these cells fairly strongly. It's not quite as dark. I mean, oftentimes CD99 in synovial sarcoma will be both membranous and cytoplasmic. It'll be both components. Here it's more membranous. Here we see mitotic figures. They're not atypical mitoses. And here's a little stronger staining with the CD99. Then you also did TLE1. I think you were considering sarcomas like synovial sarcoma and so forth. So that's a strong nuclear positive stain for TLE1, pretty uniformly throughout the tumor. And then we have some high magnification views of the tumor. So those are two very useful stains. And they do suggest the possibility of synovial sarcoma. This is a little bit more pleomorphic and atypical than most synovial sarcomas. Of course, those can occur anywhere in the abdomen, the extremities, and so forth, head and neck. They're quite indiscriminate about the locations that they like, and so forth. Then, Dr. Lin, you also reported that this patient had some weak EMA staining. Here's more TLE. I think that's the last one. But no cytokeratin staining. So is this a monomorphic synovial sarcoma or something else? This is, what do we do with these stains? One of the tools that I use fairly frequently is immunoquery. This is a tool that allows us to, we can go back and look at the beginning, it allows us to build a panel of stains using either the considered diagnoses that we're looking at, or using, if we get a panel of antibodies and we're not quite sure if we've included all the possibilities, we can put in up to 3 antibodies and see what we should expect. So if we were thinking, for example, of diagnoses like melanoma, so let's say skin melanoma, all types. If we were thinking about synovial sarcoma, all types of synovial sarcoma. And then maybe we were thinking about pleomorphic sarcoma. We could put those 3 diagnoses in and then ask it to build a panel for us. And this will come up with how all or many of the various reported markers might interact in this tumor. So here you see S100, positive in melanoma. It's positive in 24% of synovial sarcoma, but only 3% of undifferentiated pleomorphic sarcomas. SOX10 is positive in melanomas, but negative in synovial sarcomas, and so forth. So you see, this could be a useful guide to what antibodies might be helpful to me. And they, of course, mark here the ones that are helpful. This is helpful versus 2 versus 3. And if you want to see the best way to do it with the fewest antibodies, well, here's the ones they recommend. Low molecular weight cytokeratin, maybe CA15-3, and alpha-1 anti-chymotrypsin as differentiators. Now, if you don't always have these, you can say, well, I don't want to do alpha-1 anti-chymotrypsin, and it will exclude them and give you a different antibody. Oh, let's do CD10. Not quite as good, but still helpful. So if we go back and go the other way, other route with the antibodies, we can do that with this case. So I entered these previously. We're going to use TLE1, EMA, and CD99, and see what sort of a panel these 3 antibodies would give us. So here you see these are the antibody. These are the tumors that are positive with all three. So synovial sarcoma, that's by far the most frequent, all types, but also angiomatoid fibrous histiocytoma. Well, this doesn't quite fit the category of angiomatoid fibrous histiocytoma, and I'll show you some cases later. But that doesn't usually have necrosis. It usually has a cuff of lymphoid cells and an admixture of inflammatory cells. So this is not fitting very well here. Now, the other thing, though, that I think we should consider here, because the EMA was maybe the least certain of these, I think we should also look at what fits into this category of TLE1 positive, CD99 positive, but maybe only a small portion EMA positive or borderline. And sure enough, there's another tumor that fits into this category, the CIC arranged sarcoma. So this chick ducts tumors are appearing now as more people are doing FISH or molecular testing. And so that also can sometimes be separated from other tumors. I don't think this retroperitoneal tumor is a biphasic tumor. It's not even really a monophasic because it's much more pleomorphic than the usual monophasic. I think, if anything, it fits into this poorly differentiated synovial sarcoma. As you see here, we would expect the positivity. But I think if I were signing this case out, I would say malignant sarcoma, spindle cell type, differential includes poorly differentiated synovial sarcoma, and possibly the CIC arranged sarcoma. I don't think this is atypical fibroxanthoma. That's a different, clinical scenario. So that's kind of my evaluation on this tumor. I'm not the most expert in soft tissue tumors, although I'm trying to become more so. And this is a good kind of evaluation for me to show you what goes through my mind and other things that I'm concerned about, and how I would approach and sort out to find the best answer. Now, I should say that ImmunoQuery is a service that is, it was developed by a private pathologist. And then he sold it to Elsevier, or actually he sold it to another company which sold it to Elsevier. At the time the developing pathologist sold this tumor, or sold this algorithm and so forth, he had offered it without charge to anyone. But he wasn't able to maintain it and so forth. But when he sold it to the company, he did so with the proviso that it would still be offered free of charge to people in developing countries where they don't have a big budget to support a subscription to this, which is several $100s a year. I don't know how well they have enforced or how well they've carried on that tradition. But if you come to their, if we log out of this, let's see if we log out. If you come to their web page and you aren't able to communicate with them in their support center and ask for a complimentary subscription, then certainly you can send me your dilemma, and I will be happy to run the parameters for you, and print the page and send it back to you so you can begin to make your own choice about what antibodies or what diagnoses you should consider. Because I know the original intent of the original developer of this software. Comments or questions? Let's see, I see there's a comment in the chat. Yes, Supani, you're exactly right that the best test, of course, would be the fish testing for the SS18 SSX fusion gene. If you have access to the antibody, that again is more specific. But the availability of that marker is limited. In our laboratory, we don't have it. We'd have to send it to somewhere else to get it done. But we do have access to the fish testing. And I think your question, considering positivity of EMA, should other cytokeratins be done to exclude sarcomatoid carcinoma? And I would say yes, absolutely. But I believe that you did some low molecular weight cytokeratins, Dr. Lin, is that right? I seem to recall that that's what she said. The SOX10 was negative, and other markers as far as we knew. Well, with that, let me spend the last few minutes of the hour here talking about a few of the soft tissue tumors that are in the differential that we've considered. And we can start with the angiomatoid fibrous histiocytoma. So here's an example of this tumor. And as you see, it tends to have quite an inflammatory component to it. In this lesion, it's partly cystic and partly solid. And it's somewhat nodular. So here, as we look at these nodules, we see that there's sort of this spindly histiocytic component or histiocytoid-like component. We may see some hemosiderin. That's because this is also related to some of the hemosiderotic tumors. And then we will often see this mixed inflammatory pattern in some area of the tumor. And that may include areas with germinal center formation and so forth. So you can see this is very vascular. There's a lot of interstitial hemorrhage, and that's why we get all this hemosiderin here in this lesion. Let me show you another lesion here, this one from the skin. You can see a deep nodule, several centimeter or so. And notice here that we have this same sort of vaguely nodular, spindle cell, somewhat vascular lesion with some scattered inflammatory cells here amidst this. And I apologize, we've got a few stitching marks in the scan here. But then initially, did you notice here at the periphery, we have this cuff of lymphoid cells, even with a little germinal center here. So this is a nice example of this angiomatoid fibrous histiocytoma lesion. And this is a sort of intermediate grade tumor. It's a tumor that has the potential to recur, rarely metastasizes, but depending on the location, can certainly develop recurrences, and so it needs to be appropriately managed with surgery. I think I have one other example of this here. Here. Yeah, again, so notice the little capsulation, vaguely nodular pattern. You know, it almost looks like a lymph node because you got here at the periphery, you got the lymphoid cells with the germinal center. And then, but as you look at this higher magnification, you see this sort of histiocytic type of pattern, a lot of cytoplasm and a vascular background, some inflammatory cells in this lesion. Notice some of these have more hemosiderin than others. The inflammatory pattern a little different in some as opposed to others. Another lesion that we might have considered in that retroperitoneal tumor was the inflammatory myofibroblastic tumor. That has some overlap with the well-differentiated liposarcomas, because many times those can have a mixed and fairly dense inflammatory pattern. And so I've got several examples of inflammatory myofibroblastic tumor. And this is kind of a nice example. This almost looks like a tissue culture appearance here. These very spindeloid cells, a lot of eosinophilic cytoplasm, a little bit of atypia, and some vasculature in the background. A lot of sort of myxoid ground substance in between these cells. But these, of course, would stain quite differently. These will stain as myofibroblasts. They'll have some myogenic markers, actin, maybe some calponin or desmin. They may also be positive with other markers, usually not EMA or other epithelial markers in that pattern. And mitoses will be fairly frequent. And a little bit of atypia here. So you can see why this was something I was thinking we should think about in that retroperitoneal lesion. I'll show you another case that we had from our laboratory, which you can see here. And you can see, again, this sort of spindle-shaped stroma, not very high cellularity, variable streaming and nodular pattern. This is not as, it's a little bit, it is not pleomorphic. You don't have the marked nuclear pleomorphism that we had in that first case. You may have some nucleoli. Here's a cell with a nucleolus. And then you see these scattered lymphocytes around amidst the tumor, which can be somewhat variable, more in some areas, less in other areas. And it's making some collagenous tissue. That's the fibroblastic component that you see here. And then a few myeloid markers might be positive. So for example, here's this same tumor, a little bit of actin staining. You can see our control tissue over here highlights the muscle tissue. And this has a fair amount of myogenic differentiation in it. Now, this is a tumor that is often, about half the time, related to ALK mutations, sometimes also ROS1 mutations and a variety of others. So doing ALK protein immunohistochemistry can be useful in this tumor as well. Then take a look at this one. So here's a marker with CD10. You can see that CD10 is marking the germinal centers. And like many tumors, this has some CD10 staining. Now, the reason, and you may say, why did you do CD10? The reason we did CD10 on this particular tumor is that this was a pelvic tumor, and the patient was a woman. And so one of the considerations was endometrial stromal sarcoma. And this, of course, would have made us go, well, maybe endometrial stromal sarcoma, because here it is CD10 positive. However, I believe this tumor turned out to be ALK positive, and it was negative for the JAZF1 sus12 fusion gene. So we did not think that this was an endometrial stromal sarcoma. But it's an interesting differential in a female patient. You do want to make sure that you're not dealing with one of those other neoplasms that could beset you. Okay, so another tumor that could enter into the differentiation, or another lesion, is sclerosing mesenteritis. And this is a case where we had some challenges on this. Actually, let's start with the frozen section on this case. Here you can see the surgeon was operating. There was this mesenteric mass in this patient, and he wanted to know, is this a sarcoma? Can I just resect it? What am I doing? Is it a high-grade sarcoma, dedifferentiated? Well, this is our frozen section. And as you can see, it looks very low cellularity, high vasculature, but no atypia. So we were able to report this as a very low-grade, low cellularity process. We couldn't put a specific name on it at the time of frozen section, but we were able to at least reassure them that this was not a high-grade sarcoma, not dedifferentiated liposarcoma or something of that sort. It did have some fat involvement. So coming back to the resected specimen, here we see that there's some mixture of inflammatory cells that come right up to, but don't invade or destroy, the muscularis propria of the bowel. So we can see this pattern of, perivascular lymphoid infiltrate. Maybe there's a few plasma cells in here as well. I don't recall. Yeah, sort of some mixed inflammatory cells, some eosinophils, and lymphocytes and so forth in here. A few plasma cells or mast cells in the midst of the stroma, and a very sclerotic pattern or process, with some of the inflammation extending up through the muscular, possibly involving the submucosa here. And as you can see, this was small bowel that was resected. So this raised an interesting differential, one of which would be, I think, whenever you see this mixture of lymphocytes, plasma cells, and some accompanying eosinophils, you do want to think about the possibility of a IgG4 related disease. That's a possibility in a number of organs, and we'll show you some other examples of that here in a minute. But that was a consideration. Now, really the best way to make that diagnosis is to do immunohistochemical staining for IgG and IgG4. And that should highlight the plasma cells that have those proteins. And if your portion of IgG4 positive plasma cells is appreciably more than, say 20%, you're most likely dealing with an IgG4 disease. This case did not have that finding, so we couldn't establish that as the etiology. But certainly in other sites, that's one of the key features that you're going to find is an increase in IgG4 versus IgG, and this very sclerosing fibroblastic response of otherwise normal tissues that produces a mass, and obviously in this case was masquerading as possible cancer. So sclerosing mesenteritis is an idiopathic disease that may have a component that's similar to IgG4 disease. We also mentioned that dedifferentiated liposarcoma is a possibility in the retroperitoneum where you've got an inflammatory pattern. And here's my classic case illustrating both areas of well-differentiated liposarcoma, the typical appearance. As you can see here, these expanded septi between the lobules of fat, with some areas of inflammation. And in some cases of well-differentiated liposarcoma, this inflammatory component can be very intense and actually almost obscure other features of the neoplasm. So if you get a very lymphoid appearing soft tissue mass, but you have some slight atypia, as you can see here in these fibrous septi, you've got some atypical cells like this. Do think about the possibility of well-differentiated liposarcoma. So if this is all we had, we would call it well-differentiated liposarcoma, and maybe comment that there's some active inflammation. On the other hand, you do want to look at the other areas, and this had areas of solid growth, as you can see here, with high cellularity and a great degree of pleomorphism, a little bit more cellularity than we saw in our first case that we talked about. In addition, this tumor showed areas of more dense cellularity. Here we see very high cellularity. So this is high-grade undifferentiated pleomorphic sarcoma. If you just had a biopsy of this, you didn't know the story, you might call it undifferentiated pleomorphic sarcoma. And in fact, when they've gone back and studied many cases previously diagnosed as undifferentiated pleomorphic sarcoma in the retroperitoneum, turn out to have MDM2 mutations and are really dedifferentiated liposarcoma. The other feature that is somewhat unusual in this particular case is that we actually have areas of heterologous differentiation. Here we see more of that high-grade undifferentiated sarcoma. And then here you can begin to see areas of osteosarcoma with the nice osteoid coming out of the matrix here. So, we wouldn't call this extraosseous osteosarcoma in this setting because we have this gradation from well-differentiated liposarcoma to dedifferentiated with heterologous elements. We also know, of course, that there are some osteosarcomas that do have MDM2 mutation, though they're usually not the high-grade pleomorphic variety, as we're seeing here. So just a very interesting differential and progression of disease. So let's just take a look at a couple of cases of IgG4 disease. This is a salivary gland. Here's the salivary duct. Well, actually, is this salivary? No, I think this is pancreas. Let me make sure of that. I think this is pancreas. Nope, submandibular gland. Okay. So we have a salivary duct, and you can see it's chronically inflamed because we've got germinal centers here. So there's really a degree of chronic sialadenitis. And that's often the backdrop, a long-standing chronic sialadenitis. And then they develop a rock-hard mass, and you think it's going to be cancer. And so the surgeon takes it out, and this is all you find, a very dense fibrosing process, a lot of lymphocytes and germinal centers in the acinar tissues. And you can see that here. And then as we come into higher magnification, I think you should be able to see that, well, guess what? We have lots of plasma cells here, and we've got our friend, the eosinophil. So it's that same pattern we just saw in the sclerosing mesenteritis, where you want to think about the possibility of IgG4 disease. And this location, the submandibular gland, is a classic location for that process. This is IgG4 related disease. IgG4 positive plasma cells were the dominant type of plasma cells in this lesion. Of course, that's in one way good news for the patient. They don't have cancer. And this lesion can be treated and other lesions prevented by use of steroid treatment. Another common location where this presents as a problem is in the pancreas, where again, it can present as a mass type lesion and look radiographically like cancer. It can cause obstruction of the pancreatic duct, the common bile duct, and so forth with this mass formation process. And yet when we have it resected and we look, we don't see anything but this chronic sclerosing, inflamed chronic pancreatitis. Well, you're going to say, where are the eosinophils? And they're here. There's a few of them here, not as prominent, not as well stained as in the other cases, and variable amounts of plasma cells, not quite as prominent as in that earlier lesion, but you can see there certainly are plenty here. And depending on how long-standing this is, the fibrosis may ultimately dominate the picture so that you have virtually no residual acinar parenchyma, or there may be relatively little of it still. Notice here that we can also get some arteriopathy. As you can see here, a little bit of damage to the vessels. The nerves can become involved in this process. So it can be virtually almost as destructive as carcinoma, but this is eminently treatable with steroids. So this is not a disease that you want to make after pancreatectomy. You'd like them to biopsy it or do other interventions ahead of time so that you can make this diagnosis. Here's another case of somewhat similar process with a little bit more advanced and more fibrotic disease. There's more atrophy of the parenchyma here in this case. You see you've lost a lot of the acinar tissue, and you just have a few of the ducts, and you'll find the islets and so forth with this very fibrosing pattern, and fewer eosinophils as you go on and get further into the process usually. Well, we're just about through with the hour. I think I'll sort of pause here. Well, actually, let me show you one more case of this, because this can also involve the liver and the biliary ducts, extrahepatic and intrahepatic. So here actually is a liver biopsy in a patient with kind of biliary obstruction. And we know there's an autoimmune hepatitis, but this autoimmune cholangitis or IgG4 related cholangitis is also a possibility. And this is an example of that. And I'll send you the link to these slides so that you can review them on your own. But again, you see the pattern with a very rich plasmacytic. Now, come on, come into focus here. All right, a little bit better. Lots of plasma cells, a few eosinophils scattered here and about. But that pattern, I think, is your clue to think about this. Now, what do you do if you don't have the IgG and the IgG4 immunohistochemical stains, which not every laboratory has? Our laboratory doesn't have both of those stains. So we have a reference laboratory that we will send the block to or send the slides to have them done. And then they can either be interpreted there at that laboratory, or they will actually just send back the slides to us after having been stained for us to interpret and add to the remainder of the case. So that's one way. If you have no access to those stains, then you can just say, this is in the differential, and suggest that possibility. Now, there might be other things, parasitic diseases, other sorts of things that might enter into your consideration. But depending on the presentation, whether they have fever, whether it's a mass, et cetera, you may be able to pretty much narrow it down so that you can say the most likely diagnosis is, or whatever. And the other thing that you can suggest in this setting is, if you really feel strongly that that's what this is, a trial of steroids should have quite a dramatic response. So sometimes the therapeutic trial can be your confirmatory test, and quicker and faster than waiting for the stains. Well, that's kind of all I had to share tonight, and appreciate everyone's attendance. We will have the recording put up later early tomorrow, end of Friday for you. And I'll include the link to these slides, both with the recording and in other communications. Any other questions anyone wants to bring up?
Thank you, Professor.
I certainly want to encourage any of you who have other cases that you would like to present for discussion or have me discuss. I'm happy to do that, so please don't hesitate to send those either as fixed photos, or if you can do a digital slide scan, that's wonderful, and we will be happy to use them in our conference.
Thank you.
All right, well, everyone have a wonderful day, and we'll look forward to talking again in the future.
Thank you, Professor. See you again.
Okay, bye-bye.
Bye-bye.